Impact of community diabetic eye screening in hospital eye service. This is a retrospective study of 10 years. Sorry for that. Ours is a well-established screening program, which is a part of national diabetic eye screening in United Kingdom. And the county has a population of 747,622. The diabetic patients enrolled, they are 6.06%, which is 45,373. This is the various register various criterias, the eligibility, suspended and excluded. Now, this is the whole program where we have 16 members of the staff, 72 GP surgeries are being looked at, and the fixed site, there are 9 fixed sites and 3 mobile sites. There are 2 hospitals attached, Kettering General Hospital and Northampton General Hospital, with 6 medical retina consultants. They are involved in the secondary care. This is the common grading pathway. So we have a primary grading. Where there is no diabetic retinopathy, they are sent for annual screening. Any disease positive will go to the secondary, and 10% of the normal also go for the secondary for the quality assurance. If there is any discrepancy between the primary grading and the secondary grading, it will go to the arbitration grading. And at this level again, R1 mild retinopathy, no maculopathy, will go for annual screening. Anything else will go for ROG, referral outcome grading, which is the most important part here. And the referral outcome grader is the most senior grader. And this can refer to SLV surveillance, digital surveillance, or it can refer to the hospital eye service. So the central role of referral outcome grading, which is either an ophthalmologist or a very senior grader, can refer for annual screening. It can refer to SLB surveillance. It can refer to digital surveillance, and it can refer to the hospital. And after the treatment is done in the hospital, it comes back to the referral outcome grading. So this is a 10-year retrospective study. Strict national criteria are followed for primary, secondary, arbitration, and referral outcome grading. All the referrals to the hospitalized service were reviewed on yearly basis. Cohort performance measure in the screening was evaluated as per national guidelines. So this indicates the coherence performance measure. And you can see here that in 2010-11, the cohort was 30,972, which increased to 45,737 in 1920. And the routine referrals to the hospitalized service gradually decreased. In 2010-11, it was 1,709, and then this decreased to 622. The urgent referrals also, they were gradually reduced from 158 in 1213 to 77 in 1920. The total referrals to the hospitalized service also was gradually reduced. Looking at 1213 was 158, and in 1920 was 77. Looking at the reducing new blindness, the CVI issued or severe sight impairment and the sight impairment, again, that gradually reduced. We look at 25 in 1112, and this was reduced to 6. So the results were that the new diabetic registration ranged from 7.3% to 11.5%. The diabetic patient registered increased from 30,972 in 1011 to 45,737 in 1920. Out of total 251,623 screening episodes, 3.26% were referred to the hospitalized service, and 96.73% were referred back to the screening. Referral to the hospital decreased from 5.51% in 1011 to 1.52% in 1920. So to conclude, the referral to the medical retina unit were reduced gradually. Overall, referral to the medical retina unit were reduced by more than 50%. There was a gradual reduction of sight impairment and severe sight impairment registration, ranging from 25 in 11-12 to 4 in 18-19. Screening is therefore an effective tool for selective and appropriate referrals to the hospitalized service for diabetic patients. Screening is also helpful in preventing of blindness in diabetic patients due to early recognition and referral of sight-threatening retinopathy. Thank you very much.
How do you see that we can implement the same thing in India?
I think it is the most important point. I would say that the ophthalmologist should be placed in the central ROG grading, and it should be a part of any screening program. And that would be beneficial because then the quality assurance is maintained. So, and another thing is that putting at primary, secondary arbitration level, that is another important concept, I think, which should be included, where the quality assurance is maintained.
Any other question?
Author has very nicely explained the common grading pathway. We can implement in India as the incidence of diabetes is very much increasing in our country. Now the India is the capital of diabetes. So we have to take lesson from this common grading pathway by the author. Thank you.
Thank you.
Thank you.